So we've been looking at this. This is me. This is a much younger picture of me. A lot of the people that are joining these talks most commonly are patients that have seen me, because it's really just a database of patients of mine for the last 10 years. It's sad that I don't have a bigger database that goes back further, and it would be helpful. So that's me. I've done a lot of things in my career. I've done a lot of robotic surgery. I was instrumental in that, and do a lot of minimally invasive surgeries and reconstructive surgeries. More recently and later in my career, I got involved with doing some of the things that helped the men that I did robotic surgery on, i.e. Devices for erections and male urinary incontinence. So that's what we're going to talk today about, is male urinary incontinence. When we really call, and I want to make sure we really know what we're talking about here, which is male stress urinary incontinence. And what does that mean? It doesn't mean you're stressed out. But if you go to my website, dcurology.net, and you look at the tab that says educational videos, you'll see I'm going to talk about enlarged prostate issues, lots of other issues. I just gave a talk last week about kidney stones. Men leak urine for lots of reasons. Women leak urine for lots of reasons. What we're not going to talk about are those reasons that have to do with, I can't empty my bladder. That's an enlarged prostate problem. That's a different treatments and different talk. I have overactive bladder, something like that men and women can get. That's more of an urgency. I can't get to the bathroom in time. What we're going to talk about is stress incontinence, meaning when the abdominal wall is stressed, meaning I stand up, I sit down, I do what this grandfather's doing with this kid. I'm making a stance, and urine's going to leak out. That's what we're going to talk about. It's a problem holding your urine physically in your bladder. So, what is it? We've talked about it, but generally we're talking about leakage that's going to occur when you increase your abdominal wall pressure. So laughing and lifting and bending and, passing gas or anything like that. That's episodic leakage. It's spurting. In its worst case, I saw a guy like that today. The bladder just doesn't hold urine at all, and it just all comes out. We'll call that stress incontinence too, even though it's its worst form. And it's a very common problem. And that's largely because there's a lot of surgery and medical treatments and things like that we'll talk about that cause this. This is generally something that commonly is caused in many ways by the things we do to help people. So that's important, and it's a big deal, and that's why we're talking about it today. So if we want to talk about what is stress incontinence in a man, or why would a man leak, I refer to this a lot when I'm talking about prostatectomy or taking a prostate out for cancer. Men and urine are going to leak for very different reasons. Women have stress incontinence. It's way more common than in men. And that tends to be more of an aging process, a childbirth process. That's a problem of support of the bladder in a woman. That is not the problem in a man typically. The problem in a man typically is right here. So if we look at how do you urinate, this is a side view of a man, of course. So, the bladder is going to collect urine, and then the urine is going to pass through the prostate gland. The prostate gland is what I call nature's junction valve. It's basically what allows the reproductive tract to use the same channel, the urethra, as the urinary tract to shoot things out. It's pretty amazing that we use the same channel for that. But the bottom line is the prostate is hollow in the middle. The urine passes through it, and then it goes out the urethra this way. The main issue primarily in a man that leaks is a problem right here, the bottom of the bladder. We call that the bladder neck. The bladder it's just really a muscular sac, but it's much more complicated than that. It has a very different function at the bottom than it does at the top. The bottom squeezes like an anus, so the default position is closed. And then things have to happen with your spinal cord to tell it to open, to allow urine to flow. You have your own voluntary muscles that you can squeeze. We call that the external sphincter. So that's what you would squeeze on your own. You could squeeze it now and feel it. You can't do anything to your own bladder neck. So those are the continence mechanisms. Rarely the problem in a man who leaks is that the sphincter is wrecked. That's kind of a thing of the past. Primarily the problem is that the bladder neck won't close all the way like it used to. So if it's been radiating, and it gets fibrosed. So it's just stuck in an open position. That would cause you to leak. It's like having a hole in the bottom of a Coke can. It's just going to fall out. Sometimes with surgery, we'll talk about that, where we fool with the bladder neck. It just doesn't heal back how it was before, or other conditions that scar it, neurologic conditions, spinal cord conditions. We'll talk about those. But the problem in men tends to be that this bladder neck just doesn't pucker down like an anus like it used to. That's the problem in men, not women. And we've already talked about this. I've touched upon it. What causes it? Certainly prostate cancer surgery does it. It doesn't just have to be prostate cancer surgery. It can be enlarged prostate surgery. I saw a gentleman today who had complete incontinence, kind of a strange story. He's very much looking for it to be fixed. He's going to, I think, have a problem with his bladder neck. These slides are slides that I don't necessarily tell my patients, and I don't agree with the percentages, but the ideas are correct. It says up to 50% of men report leakage after surgery for prostate cancer. Any of you who've had surgery with me know that I'm going to say all men leak after prostate cancer surgery, but it usually goes away. And it usually goes away in my series better than this. I don't have a 9 to 16% rate of men having incontinence still at 1 year. It's probably more like 5 to 10%. But you know, if you consider the fact that I've done 3,500 robotic prostatectomies or so in my career, that's still a lot of men, even at 5 to 10%, that still have some degree of leakage, and I don't want them to leak. So I tend to be very much one who doesn't sweep it under the rug. I try to be very upfront and ask about it because I want to offer to fix it for patients. So we've talked about these other issues. If you have pelvic trauma, if you get in a car accident and you break your pelvis and you have a bunch of bleeding in there, that also can hurt your bladder neck. So these are all things that are going to affect your bladder neck, and it won't pucker down anymore. This is just a few slides talking about prostate cancer treatment. That a prostatectomy for cancer is the act of severing the prostate from the bladder and then cutting the urethra. The sphincter would be further out here, and then putting the two ends together. And, you know, if nothing weird happens, then usually this bladder neck is still intact. We try to keep it as small as possible, and it will regain function. A man after prostatectomy always leaks because the bladder neck always knows it's been fooled with. So it's going to take some time to wake up and start to pucker back down. When they're going to stop leaking is when their bladder neck wakes up. We're going to talk about things like Kegel exercises and pelvic floor exercises in a minute. Those are things that I don't really think help a man too much after a prostatectomy, because those just work on your sphincter muscle over here. It doesn't have to do with your bladder neck. But the point being is prostate cancer treatment causes incontinence, and not everyone gets their continence back. So they need help. And so what do we do when a man has this stress incontinence? And again, we're not talking about urge incontinence. We're not talking about the type that would come from not emptying your bladder. That's called overflow incontinence. Those we talk about in other talks. But what does a man do when they leak? And it's generally, you know, this is what they start to do. Maybe the first thing they're going to do is, and you can see it starts to control their life. Maybe they starve themselves of fluid because they don't want to, you know, they just don't want to have to urinate. But that's not a good long-term option. They might say, I'm going to go to the bathroom every 45 minutes to try to keep my bladder empty. That's not really a great option either. We talked about these things, and they're very popular and they're very common. Big institutions that do prostatectomies that tend to kind of own a clinic with a rehab person will sometimes automatically send patients to them. I really only found things like biofeedback or Kegel exercises, which is just the act of squeezing your sphincter, or pelvic floor therapy, which is teaching you how to squeeze your sphincter. I only find that to be helpful in those men that just can't grasp the concept of what we're trying to teach them in the office. It's pretty obvious when that occurs, and they do leak a lot. But since the sphincter muscle that you squeeze, that voluntary one downstream, is not your bladder neck, I actually find that even patients that don't use their sphincter much, eventually they'll get dry. They'll just leak more and take longer to get dry until that bladder neck puckers down. But I do employ these things so a man can help himself until his own bladder neck helps squeezes. And then ultimately, this is the mainstay, is to wear pads or diapers. And I can't remember the exact phrase, exact period of time. I do know, and certainly this has changed a little bit, but very commonly people will need a prostatectomy and they'll travel to a big institution because they're getting the assumption that something better is going on there. And the problem is they don't follow up there. It's a shame because really, if you don't follow up with the surgeon that made you incontinent, you don't tend to be told of how to fix your incontinence. So many men walk around. Every city has a huge major institution that's a referral center that people go to for surgeries, but they walk around not really having been counseled of the solutions. And so the average time to actually getting incontinence fixed is something like 9 years, because people will leave their urologist, they'll go somewhere else, they're assuming everything will be okay. They go back and they don't see their urologist, they see their internist, and they are not aware of their options. That's a very, very, very common story. And that's one of the reasons I give this talk. It's just hopefully people will find this maybe in another city. My website gets about 45,000 hits a month, certainly not from all my patients. And hopefully I'm spreading the word on, you do not have to continue leaking. There's no reason to live with that. There's easy solutions. Some things that I really am not a huge fan of at all. I really don't have any patients that I knowingly use these things, but there's things called condom catheters where you'll put a condom on your penis basically, and it just sort of leaks and traps into a bag on your leg, or clamps to actually just clamp your penis. This is a patient's prerogative, but I'm very much against these because it's just a function of saying, I'm going to give up, I'm going to live with the leakage, when the fix tends to be so simple. In my practice, I tend to try to say, why not just fix this? But these are all the options that exist that are non-surgical in nature. This is just pointing out that pads really are a rip-off and they're very expensive. Penile clamps and these condom catheters really aren't perfect. And that doesn't need to be there to convince me. And the fixes are pretty straightforward. There are competitors to this company that's hosting us tonight, Boston Scientific, but really they don't have much market share for their devices. There's some competing slings. We're going to talk about that in a minute. I've always found the Boston Scientific products to be straightforward. Almost every urologist I know just uses those. So we're just going to talk about those tonight. I will say that throughout time, even back when I was a resident, which is a million years ago, that I was looking at my picture on this slide, and it's a much younger version of me, people were working on versions of slings in men. They've always been slings to fix female incontinence that are very, very successful. But over the years, there have been constant reiterations of the concept of a sling or something to pull up or compress the urethra. I remember being part of the development of one in residency, but it's really kind of evolved now where there's something called an advanced male sling. That's sort of the latest version, and now there's another version of that. So we're going to talk about that. But other than these other sling systems, there have been attempts at injectable things like collagen. If you could go to the bladder neck and try to inject all this stuff under that, maybe that would like pucker it down a little bit. Those have never been successful. The particles have migrated and caused trouble. So that just hasn't been the answer. So really we're talking about two answers now, two procedural answers. There's no magic pill. I could point out that every now and then, if I see a patient with a very small amount of leakage, barely one pad, I might try an old antidepressant called imipramine. It's not used as an antidepressant today because the antidepressants today have few side effects, but imipramine has a fair amount of side effects. But the main side effects had to do with its effects on your bladder. It tightens your bladder neck. It gets your bladder neck to squeeze a bit and calms your bladder down. So imipramine sometimes can be the difference maker for someone who barely leaks. And if they can tolerate that, that might be something I try before we talk about procedures. But if one is really wearing a pad and it has to be changed such that it actually gets wet, That's usually a procedure thing. A male sling, which I'll show you a picture of, is a simple device. It's really just mesh like you'd see in a hernia. It's not the same thing as the pelvic mesh that used to be on all the class action lawsuit commercials. It really doesn't have much to do with that. That's a whole different thing in women. But what it is well, I'll show you a picture in a minute. But it's the idea is to do something with the urethra, the urine channel, just past the bladder, such that you're going to actually pull it up into the bladder and create a little bit more pucker. So it's for people that leak a little bit. I'm going to say less than 2 pads a day. Less than 2 pads a day tends to be my cutoff. That's certainly enough to be annoyed. You don't want to wear a pad all the time, but it has to just be mild incontinence that way, in my practice, for the sling to make sense. But what I always say it's doing is it's finishing the puckering job. If you only leak a pad or two, it means your bladder neck mostly closes, but not quite all the way. It needs a little more help. That's what the sling does. It doesn't just compress the urethra, it gets the bladder neck to pucker. So make sure I cover these points. The results are immediate. It's really a 1-hour procedure. That's an outpatient procedure. Patients are happy with it, of course, because they get out of pads. And no one knows you have it, and you really don't have anything to operate. You just urinate normally, and that's why it's so appealing. Most people ask for the sling, but it's only good if you have mild incontinence, 2 pads a day or less in my practice. This would be, a schematic of a urethra, and this is the wider part. Further into the patient, there would be the bladder, and you're basically making a small incision under the scrotum. You're showing yourself this urethra. You're mobilizing it so it can move. And then with some special needles in the inner thigh, you're passing the needles down here to pull the sling up, attaching it to the urethra, and then pulling it up. There used to have to be the demand that a patient would, not do a lot of things that caused a lot of leg stretching or bearing down real hard, because the sling would be pulled up and the patient would be dry and they'd be happy. But if they did those things, or they were constipated and pushing really hard, it could pull the sling down a little bit and it would slip. The latest modification is just these sort of one-way hooks, one-way barbs on here, so it really won't pull down easily. So there's even less of a imposition on having to avoid heavy lifting or leg stretching like there used to be now. And that's what a sling is. And again, if someone's wearing a condom catheter or a clamp on their penis or pads, and they're only wearing 2 pads a day, I hope I'm known for not talking anyone into anything, but I am certainly at 1 year after prostate surgery going to say, it's not going to get better. It's time to decide. Do you want to live with it or do you want to fix it? But this is a great fix. I have a very high success rate in my practice, probably 97%. Pad free. I am getting old to the point where I'm starting to have patients that have had a successful sling in, and they're starting to leak a little bit again. Maybe just a pad. In a literature, in a paper that we would write, you're considered dry if you're only wearing 1 pad, but that's enough to make someone annoyed. The problem is, it's not that it so much loosens, it's that maybe just the patient's anatomy has gotten more lax as they get older. But if the sling stops working, it's funny because people will live with incontinence. It's amazing that you'll meet people that have 6 pad a day incontinence. Not my patients usually, because I fix them, and they're just so used to it, they live with it. Once a person is dry, once a person is fixed, they may have struggled with the decision to get fixed for 9 years. But once they're fixed, they usually don't tolerate leaking after that. They usually very much say, I want to be dry again. But after a sling is not working perfectly, we usually have to then talk about a sphincter, because it's not, you can try to remove a sling and then replace it, but it's very difficult. And generally it's in a setting of a complication more so than a fine tuning. So that's a sling. That's what I can tell you about a sling. We'll talk about the risks later, but the risks are very low. The other device, and this is the one that's really been the gold standard, this one's been around certainly before the sling was, at least this version of the sling, is called the artificial urinary sphincter. And what is that? Well, if we can remember that schematic, and we can remember that we have to urinate through the urethra, etc. It's just, I'm going to show you a picture in a minute, but unlike the sling, which has more of an anatomic component of pulling it up and puckering the bladder neck, this is going to leave the bladder neck alone. This is going to be something down the line in the urethra. X this out, something down the line in the urethra that is going to be like a blood pressure cuff, but it doesn't blow up with air, it blows up with water. And the default position is that it's blown up, so it's just compressing your urethra inside. It's doing what a bladder neck would do if it was working perfectly. It's just not squeezing the bladder neck, it's squeezing the urethra, and we'll talk about it. People do see this as a bigger mental hurdle. Now I have this artificial device in me. You do actually have to do something to urinate, which is just a single little squeeze of a pump. It's no big deal. Patients immediately get used to it. Every man kind of has a routine when they urinate. It just becomes part of their routine. No one next to you in a urinal would know that you're doing it. It would just look like you're positioning yourself. And so actually, eventually, patients don't even mention the sphincter to me when they're seeing me down the line in the office. It just becomes how they urinate. We'll talk about it in a minute. But this is going to be for higher degrees of incontinence. This is going to be for anything really above 2 pads, but certainly the gentleman I met today that just pretty much stands up and all of his urine leaks out. That's a job for a sphincter, but even 3 pads is a job for a sphincter, in my opinion, because it works. It very much works. So it mimics a healthy internal sphincter. That's what we call the bladder neck. And no one knows you have it. That's for sure. This is a schematic. There was a movie that doesn't work so well, but I prefer, so I deleted it, but I prefer this schematic here. This would be a left-handed person because this pump, which is in the scrotum, nobody sees it, it's all in there, is on the left side. If you were right-handed, I'd put it on the right side. But there's 3 components to this. There's that blood pressure cuff that I put on there. That's something we size specifically to you. And then that has to have a water source, which generally is a small balloon. What we do is we put that underneath your pubic bone, so you don't know it's there. You can't see it. It's under the bone there, but it's there. And then there needs to be a pump that's going to pump the water out of the cuff because it's inflated, and then pump it out so it opens and it just pumps it into this balloon. It takes maybe 1 squeeze. That's all. 1 squeeze. If you go to my website, dcurology.net, there's actually a video of what does it look like when it opens and then when it closes. It gives you about 45 seconds in the open position, which is about the average time an older man takes to urinate, and then it just automatically inflates again. You don't have to do anything. There's nothing special to do. You need to urinate, you press this thing once, it opens, you urinate standing up, however you want, and then it closes on its own. So it's really a pretty remarkable bit of engineering, and it absolutely just becomes part of your life. You don't know it's there. It's no big deal. Just like the sling, it's an outpatient procedure. It's small incisions. It's not a huge operation. We do not activate it immediately. We'll talk about the risks, but we don't want this squeezing on a urethra that I just dissected. So you have to give it 4 to 6 weeks to heal. We deactivate it using this button, so you still leak afterwards. You let everything heal, and then you come to the office, and the actual rep from the company that helped put, was in the OR while we were putting it in you, he knows you. He's going to teach you how to use the thing until you're comfortable. Boston Scientific is incredibly wonderful about supporting you and making themselves available. They want you to be happy, and they want this to work. So I always connect you with the rep to do this. And then the day you come in, you activate it by merely pressing it, and you see a man that maybe for the last 10 years has gone from wearing diapers and constantly leaking to being dry out of pads, and that's what we're always shooting for. So it's a very gratifying moment when we activate a sphincter. It tends to be more gratifying than the sling because the degree of incontinence generally is worse. So that's the story there, maybe 1 or 2 incisions. And this is just basically saying that patients are very happy after they have it. No question about it. They're very happy. important thing about cost. I mean, people, this isn't cancer. People don't have to have this done, but these things are always covered by insurance. I mean, I shouldn't say always, but I've certainly never, ever heard of them not being covered by insurance. That's not always true with the penile prostheses that I talk about from this company. But certainly there's the insurance doesn't consider fixing incontinence elective in any way. And let me just make sure we talk about, yeah, I want to make sure we talk about the risks and things. And so again, you know, why should you have a procedure? Because you don't want to wear pads. I always tell people, you know, you're not, we can cope with anything. We really can cope with anything. It's amazing what human beings have to cope with. Soldiers come back having to cope with their injuries. They just don't have a choice. They have to cope. But you don't have to get used to this. And I really don't want my patients to get used to this. I want them to consider this as a part of their cancer treatment. They were judicious in deciding they needed to be treated. It was part of getting them back. You know, how hard they want to work on sex is a different story, but I do tend to push patients to be dry. And so this is why you do it. People are happy when they do it. It's also an important part of, you know, maintaining, getting back to your sex life, etc. You know, people are just not going to go there if they're leaking like crazy. So if I have a person that's having problems in both regards, I'm going to really push them to get their incontinence fixed, so then they can make more of an objective decision of how hard they want to work on their sex life. And now, what are the risks? There must be a catch. This sounds too good to be true. You know, what are the risks of these procedures? And the answer is there's not many risks with the sling, that's for sure. I mean, I guess you could say it doesn't work. It is not for radiated patients. I should have said that before. It just doesn't work if you've had radiation. And the reason for that is it has to work by having the tissue be supple and push the urethra into the bladder and have it pucker. And with radiation, it just doesn't pucker. That's the problem. So radiation equals sphincter. But in terms of infection or erosion, things that we're going to talk about with the sphincter, it doesn't happen much. I actually have never seen it, to be honest with you. So people can, when they first get their little catheter out the next day, they can have a hard time urinating because all of a sudden their bladder went from not feeling any resistance to feeling resistance. But actually, when patients can't urinate the next day, I actually see that as a good thing, not a bad thing, because it's near 100% success. Your bladder will get used to that obstruction. It will get a little stronger. It'll urinate through it. It's like having your prostate back all of a sudden. So it's not the end of the world. I've had one patient that, for whatever reason, he just could never actually totally urinate, and I had to remove the sling, and he still dry and had a good result. Post-op pain is usually minimal. We used to talk about pain in your thigh, but it's something I really just have not seen. And so this is kind of a relatively low complication rate problem. The artificial sphincter, on the other hand, it's also a very low complication rate thing, but we always need to understand that that device is around your urethra and it can erode into your urethra. It can, especially in radiated patients, and this is specifically in radiated patients, where the tissue could break down, and that'll be evidenced by infection. So certainly patients of mine that have had a sphincter know no one else treats you for infections. You never just go to an urgent care and get antibiotics. We always have to assume the worst. And if it does happen, in the worst case scenario, you have to take it out. It incredibly heals. It's amazing. You would think it would heal with all this scarring, but it generally heals, and you can then just come back and oftentimes replace the sphincter. And patients almost always ask for that because they tasted dryness and they want to keep dryness. But infection and erosion is what we have to be on the lookout with on the sphincter side. This is just a website that Boston Scientific provides, and you're free to go there. Of course, I would rather you go to my website, but this is their website, fixincontinence.com. Mine is dcurology.net. And I kind of have to slide through these references, and they're there on a recording if there's any reason you want to see them. A lot of them, in my opinion, are kind of old. You know, here's one from 2005, for instance. And that is my talk now. So again, we're going to try to